So good morning and good afternoon to everybody. My name is Sana Rockwell. I am a healthcare leader for 25 years now, passionate about health equity and improving outcomes. Today, I want to share, actually, I'm going to build on what Mette Maria just said. Thank you so much for that talk. I'm hoping that you'll see how we build on the work together. For me, the lens is really human-centered technology and how that can be a catalyst for healthcare transformation. As Dr. Kohli mentioned earlier, I've been in operations as well as in strategy in healthcare. And in this example, a lot of the work I will talk about comes from my experience in patient experience as a director. And one of the key learnings for me is how it all comes together. And I think Dr. Kohli and Mette Maria already made that point. So I'm hoping to build on it. So to start with, what I would like to do, if I can get my screen to work, there we go. Sorry, one second.
Sana, you're muted.
Okay, do you see my screen? Sorry.
We see you.
You see me. That's not, well, that's good if you see me, but it's not good that you're not seeing my screen. Hold on one second. I'm gonna try it again. Huh. So were you hearing me earlier when I was talking or not?
We could hear you, we could see you like that, yes.
And now it stopped. Okay, just give me one moment. Entire screen, yeah. Share. I don't know what happened.
Yes, we can see you.
Okay.
We can see your slide deck, all right?
You cannot, not yet.
I cannot, yeah. It's saying you've
Okay.
started here.
Can you see your slide deck on your screens?
No. So give me 1 second. It says has started screen sharing, but it's not showing it. Sorry, 1 second. I'm gonna cancel the screen sharing and start again. Share screen. Entire screen. Window. Okay, now
There.
you should be able, there
Yes.
we go. Thank you. All right. So sorry about that. So as we start today, I want to talk about what is human-centered technology, the impact areas, and then I'll go through a case study, as I mentioned, from my experience as a director of patient experience, look at success factors, and just looking ahead in terms of how technology can be used to do all the great things to enable the things that we talked about, which is really quality outcomes at the end and patient care. So as we start, I just want to see, maybe you can put in the chat as we talk, how do you currently use technology today to improve healthcare outcomes and operations? So if we can have the participants just put in the chat the answer from their perspective, please. I'm guessing we're able to see their chat. Am I right?
Yes.
Okay. So I'll give people a few seconds or so to just type in the chat, how do you currently use technology to improve healthcare outcomes and operations? No, I don't see anyone typing. Is it because they don't have access to it? Or is that not not an option right now?
I'm going to ask one of the organizers here. I can see the chat box. I
Yeah,
don't see
me
any.
too. But I know we had separate logins. Oh, see, ours says to hosts and panelists, Manish. So maybe
Oh, yeah.
that's not gonna work.
Yeah. Dr. Shetty or Mr. Batula, is there a way for us to get audience responses, or should we just proceed?
So, yes, sir. Sorry,
It is
come
open
again,
to
sir.
the chat. The chat box is open to the audience.
Okay.
In case they put in, it will come up.
But
Even
can we
not that-
see it?
Yeah.
Can we see it if we're in a different Zoom link?
Yeah, we're not able to see it. So
Okay,
let's just.
that's fine. Let's move on. Sure, let's move on. So basically, I wanted to understand how are we currently using technology, and then what do we wish technology will do? And I think as we think of those questions, as I go through the presentation, we'll see really the key is what Dr. Kohli mentioned in the beginning. It's really not the technology, right? It's the humans who are driving the technology, who are using it, and technology enabling what we want to do. So as we think of human-centered technology, we want to think of how do we prioritize the needs, experiences, and values of the users. And the users can be our patients, they can be our nurses, as we heard earlier, our physicians, our families, and other caregivers, of course, that are involved in the healthcare system. So human-centered technology incorporates empathy and curiosity to understand first the needs. It, of course, involves designing the technology. I think Dr. Kohli mentioned right from the beginning, technology has to be intuitive, it has to be user-friendly, and ethical. So from a sense of equity, we always want to have that lens. And then technology, human-centered technology, when used effectively, actually empowers the users and aligns with their values. So we're constantly feeling that the technology is actually helping lift up our own values. So the impact areas in healthcare, yes, absolutely. Operational efficiency, right? And Meta Maria gave us some great examples, both on the quality as well as operations, right? You can reduce administrative burden. If we can get access and when we can get access to real-time data and predictive analytics, we can optimize our resources much more effectively. Supply chain management, when using technology and helping us streamline our supply chain processes. Obviously, interoperable systems are going to be crucial as we look at technology and how to best leverage it. From a access, quality, and equity side, when we can have seamless documentation, we can have the data sharing, so the different platforms talking to each other, so that a patient's information, the example that Meta Maria gave was wonderful. Like, it doesn't matter where you are, you go in, you put in your ID, it knows who you are, you can get your test done. So that process can be seamless. With that, you get improved care coordination, so people can actually know what's happening about your care, and then you get more effective care. So telehealth we touched on as well, wearable devices. You know, my daughter was actually, she's young, but she had an issue that gave her high blood pressure. The physicians were able to give her a remote blood pressure monitoring unit for a day. She was not happy to wear it all day, but it gave them information over 24 hours to understand. And thankfully, we just had to mail it, because otherwise it was 2.5 hours drive to get to the doctor and 2.5 hours to come back home. So as technology gets better and better, how can we get the information we need so that the patient can get the quality care they deserve and get their care where they are at home, for example, in this situation. So wearable devices are going to be a crucial part. And then, of course, as we mature, early disease detection with AI and machine learning, which I know is already happening, but it's getting better and better. Now, the engagement and experience part is the part that really is where I did a lot of work in. But what I hope you'll see as we talk today is these really are interwoven. And again, Dr. Kohli showed that slide where it is not the silos. And the less we think of our work as silos, I think, the more that we will be effective. So as we think of our meeting our patients' needs, looking at population health, so data and how we can use it at the point of care to understand our population, addressing social determinants of health. We know that a patient's clinical condition is really actually 20 to 30% of the care that they need and of the issues. So looking at what else is contributing to the disease progress, and then streamlining our processes and enhancing our work environment. So as we think of these three areas, I would like to share with you, a case study. And in this case study, this was in a trauma unit in a 600-bed academic medical center here in the United States. And what was interesting is the reason I got to work with this group, I was director of patient experience, and their nursing director, Nata Maria, not only because you're on the phone, but I will tell you, I could not have done my work without our nurse leaders, without the nurses on the ground. It was a true partnership, and really you could see the beauty of collaborating and the impact on the patient, on the nurses, on the physicians. It was one of the most inspiring work I've done, to be honest. So in this situation, the nurse director said, I need help. Like, everything we've tried is not working. And a lot of what we were doing, honestly, was like top down instead of taking the time to listen and understand from the front line what was happening. We had low patient experience scores, especially when it comes to nurse and physician communication. We had decreased employee engagement and morale. There was concerns about the quality metrics and outcomes. So we decided to work on the trauma unit. Now I have to tell you, a lot of people told me, this is not something we can fix. The patients come in, they're all inflamed from the trauma, they're swollen, and the doctors don't know what's going on. So the patients get frustrated because the doctors aren't communicating to them, and the nurses are frustrated, but there's nothing we can do because everybody has to just wait, and nobody likes to wait. So if you know me, you know that I like complex problems. So this was a problem I was willing to take on. And what we did is we used human-centered improvement, also called human design, if you're familiar with it. It's a problem-solving model where actually empathy, or you can call it research, but understanding user needs is at the heart of it. So we start with identifying the challenge. We then go and actually listen. We listen and we're curious genuinely about what is happening, not just with the data. So we use the data, we need the data. It tells us, gives us kind of the first impression, but then we actually take the time to go, and you'll see this in the next slides. We take the time to listen to what is happening. And then we actually co-create solutions with the people who are at the front line. In this situation, it was mainly our nurses, but we worked with the people who are our environmental services and housekeepers, nutrition, our physicians, we met with them. And then after you co-create solutions, you implement, you continue to refine, just like any quality initiative that you work on. It's a cycle, so it's not a one and done. And then there's always the debriefing, the follow-up, and then you spread, right? Whatever you learn, if there's some good things, you can take it to other units. So in this situation, we were actually able to start working with the transplant unit as well, after we worked with trauma. So what we did for the empathy phase is We interviewed 3 different roles: administration, management, nursing leaders, as well as the nurses who have been working for more than 1 year, and then new nurses. And we started very simple. This was in person at that time. This was before COVID. And we met them, like we did 7 a.m. So when shifts were changing, and I think we did maybe like lunch hour. So, and then evening as well. So we tried to accommodate all shifts. We wanted to hear from everybody that we can as much as possible. And of course, we worked with the nurse director and the nurse manager to make sure that people could come and join us. And people love when you give them food. So we made sure we had food so that they can come and eat and talk to us. So we said, hey, what's going well? What do you enjoy about what you do? What are some challenges? What's not going well? And then if you were to define the highest priority issues, what would those be? So from there, we took a lot of notes and we started to get some ideas of what people are thinking. So there was a lot of sense of pride, which is great because that keeps them coming. They love what they're doing. They're working in the only level 1 trauma center in the city. They feel like it's a great place to learn and they don't feel judged if they have questions. Very high morale, and then there's a great teamwork. So that's things that we can use to leverage as we drive improvements. So you want to start with what's going well and then what's not going well, right? So the residents, medical residents, don't realize that the nurses have tried everything before calling them. So there was some tension between the physicians and the nurses felt like there wasn't an understanding that they're trying their best. There was some things about orientation not long enough. They felt like they weren't ready to come to the unit when they started. They didn't, of course, we all feel like there's not enough help. There's not enough nurse assistants. And one of my favorite was a nurse saying, I just want to be a nurse. I don't want to have to run around looking for equipment. I don't want to run around trying to figure out how to get things that my patient needs. I just want to be a nurse. So what we were able to do is qualitative analysis. So we had 475 comments. We divided them into strength, challenges, and high priorities. You can see there was a lot of challenges, almost more than double of everything else was the challenges. So then, okay, what do you do with 267 challenges that were given to you? We were able to theme them. So there were 10 themes. So now you take the data that you get and then you try to make sense out of it, the qualitative data. So we had 10 themes around attrition, so people leaving. Also comfort measures, so things to do that help a patient feel better. Coordination, how are we working together properly? And then just this feeling of pride in what we do. So there were 4 high priority areas. You can see them circled. So now we say, okay, the next phase is ideation. So how do we co-create solutions from what we heard? Now we have our themes. We know there were things that came up. Now we went back to the same people and we said, okay, with each of these categories that you told us about, what are the actual challenges you encounter? And then for each of the themes, what do you think would be good solutions? So I'll tell you, this was a great learning example for me, learning experience. So we gave them stickies and they wrote down their notes. And you see this circle here, the red circle. What this says is Dynamap, 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 Dynamap. And I am not a clinical person, so I had to ask, what is a Dynamap? And if you don't know what a Dynamap is, it's a name of a machine. It's a brand, but it's really just what the nurses use all day to take blood pressure and thermometer and temperature. So they're walking around the units, obviously every 2 hours. They have to do vitals every 3 hours at night. So to me, this was very interesting that this came up so many times, and we started to understand why. So it turns out these machines break, and the nurses are running around trying to find a machine. They only have 2, sometimes 3 on every unit, and all of them need them. So they spend their time searching for equipment instead of being able to see the patients. And one of the things for patient experience and quality is to check on your patient on a regular basis. So we were getting information that says the nurses are not coming in when we need them to the room. So instead of, thinking the nurses aren't doing their jobs, we started to understand why can't the nurses do what they want to do. They want to go check on their patients. Instead, they are having all these difficulty finding equipment. They're having difficulty even getting a cup of coffee for their patients. So they go and get their patient a cup of coffee. Well, that takes a half hour by the time you get to the cafeteria, etc. So the nurses were actually experiencing a lot of frustrations on their unit while they were trying to do their best to take care of their patients and their families. So we learned a lot through this process. As we continued to co-create solutions, it's kind of like a funnel. We got the data, we got the feedback from the ground, from the people doing the work. We themed the feedback into the areas that we thought were high priority, which was they felt a lot of time pressure. There were issues with equipment and issues with people staying on the unit because of, honestly, burnout. And then we got to interventions. So now that we know the problems, what can we do about them? And we actually went to the senior leadership team, of course, and we had buy-in all along, which was really exciting. So this is where now the technology comes in, right? We keep saying it's not just the technology. And honestly, part of the problem was we had gotten some technology and people weren't using it. And then the CEO of the hospital was very frustrated and was putting some of the nursing units on like action plans, corrective action plans, and they were getting frustrated. So in learning about what gets in the way, we were able to remove the barriers so that our nurses and our leaders and physicians can actually use the technology in the way it needs to be used, and then get the outcomes that we were looking for. So one of the things we learned, as I mentioned, with the vitals machine, is they break. Clinical engineering comes to get them, and then they never see them again. There was no process to get a replacement. So we partnered with clinical engineering. We were able to optimize the process, the maintenance process. We also found out, by the way, that what breaks on the machine was the thermometer, and that takes 3 minutes to fix. And the machine does not even have to leave the floor, the unit. So, and then we on the back end, there was actually a problem with the ordering process and the timeline for ordering that thermometer. So again, technology is great when it works, but if it breaks down, what do we need to do to make sure that we have a quick process, a streamlined process to fix it? So these were examples that seemed really simple, but nobody had looked into it. There was a lot of frustration about the machines, the vital machines that are needed, not being available. So we found out what the problem was. We streamlined the process, and this was great timing because clinical engineering leadership was actually going through a process to implement a platform, a tool that helps track requests and progress for maintenance. So it was actually a win-win in the end for the nurses, for clinical engineering, and of course for our physicians as well. Talking about physician and nurse communication. So we had pretty low scores. We had a rounding program. We had a tool, but it was not being used effectively. So we were able to refine the tool after we understood the challenges. and we were able to work hand in hand with our nurse leaders and our nurses on the front line to revive the tool and be able to track how many patients were seen every day by the nurse, what issues came up, and we were able to give the nurses an ability to send requests right from the tool. So for example, if the patient said, well, nobody came to clean my room today, the nurse could actually send a notification to the director of the housekeeping department to give them that feedback. And then there was a way for them to respond and to close that feedback loop, close that request. So that was actually the last 2 points you can see on the screen, where we leveraged the rounding program also. And of course, it wasn't just technology. We showed up every day to check in with our nurse leaders, to check in with our housekeepers. And I'll show you in a moment, we saw great progress right here. You can see we started this process. We were about 57.4 percentile, which is pretty bad in terms of where, sorry, not percentile, our score, when we started. And we saw a great increase. And these are quarters. So we sustained over 6 months and continued to sustain after that. So this is our overall rating, rate hospital overall. And then the cleanliness, you can see the cleanliness went again over 6 months. We were able to sustain. We went from almost less than 50 to 62 to 76.7, and that unit has never seen that score before. So this was part of the last phase, which was a debrief, follow-up, we spread. So it's easy to say, you know, this is a great success, we're done and move on. But we also know that persistence and focus is really important. So we continued to focus with this team, and we started to work with the transplant team. They actually came to us, which was great. Instead of me as director of patient experience trying to convince people to, you know, do the things we need to help the patients feel cared for. By the way, communication is also just as important from a quality perspective. And what we found is when patients don't feel like their caregivers, their doctors and nurses are talking to them, they question their quality of care. You could be the best hospital, you could have the best outcomes, but if you're not talking and you're not communicating to your patient or their family member, I should say, the patient and the family does not feel like their care is high quality because they don't trust what's happening if they don't feel like that they are being communicated to. So we were asked to come help the transplant team to do similar work. And really that was some of the most inspiring work that I have done in healthcare, and working hand in hand with every level, from partnering with our nurses, partnering with our physicians, and partnering with our support staff. It was absolutely team effort. We would show up on the unit every morning, the multidisciplinary group, and check in and see what needs to be done. Very collaborative. And at the heart of it, thinking of our success factors, first and foremost, there was leadership buy-in. And honestly, without the leadership buy-in, without the director of nursing coming to me to say, I need your help, and without our CEO saying, yes, this is something important, we need to focus on it, and we need to use this approach, this would not have been successful. Dr. Kohli mentioned in the beginning outcomes. Absolutely. I would say outcomes and data, they're both important, but they're not the same, right? So we have the data, we have I know the numbers for patient experience, but that's not the same as setting an outcome and knowing what we want for our outcomes, whether it's the quality outcomes, our patient experience outcomes. So working hand in hand with our nurse leaders, we defined our outcomes, we looked at our data, we saw where we wanted to go, and then we had a plan. Thinking of allies, like who are those early adopters? If the nurse manager from the trauma unit was not open to this, again, it wouldn't have worked. It's reaching out to our physician leaders, knowing who is willing to come participate with us. That was crucial for us to be successful. As I said from the beginning, my approach is always human-centered, and I found this to be the most effective when we focus on our patients and families and our team members. What I don't have the data for here is our employee engagement, and those scores went up because when our employees felt like we cared for them also, when they saw that we were listening, when they saw that we were working hand in hand to support them so that they can do what they love, which is taking care of their patients, then their morale went up and their engagement went up. So it was really a win-win in every way. We said this before, but I'll say it again. Technology is not the project, right? The project is a clinical project, and I think it was when we were preparing Dr. Wendy who mentioned this, and I wrote it down and really resonated with me because that's really how I've always seen it. We often want to throw technology as the solution. And in this case, we had the technology, we have a rounding tool. Yay, look. It's, it has, as we say here, the bells and whistles, but it was not the answer. The answer was the humans who had some real difficulties and real challenges that they needed us to help address. And then when we did that, the technology was the enabler that helped us track progress, that helped enable some of the interventions. But first, the human part. And I think for me, as innovators, as transformation agents, as people who care to make a difference in healthcare, we have to be willing to fail. And the term I love is fail forward, right? We're gonna make mistakes, but we want to learn from them very quickly, and keep innovating. So as we think of that, looking ahead, yes, there will be more technologies coming up. I think you guys already know some of these things, augmented reality, 3D printing, of course, and blockchain for secure data sharing. And there's going to be more. The human mind is very creative, and I think it's a beautiful thing. At the same time, I think what's really going to help us use technology in a productive and meaningful way is the collaboration, the partnerships that we're going to build, and keeping our patients at the center of everything we do. And that's it for me.